Hello, everyone around the world. Welcome to the 7th IWMF Global Educational Webinar. I'm Joel Rosenblit, a WM patient diagnosed in 2006. I was watch and wait for 8 years, and then I developed peripheral neuropathy, mainly motor neuropathy. I was treated for the WM, and the neuropathy got better. I still have some mild sensory neuropathy. I'm a volunteer with IWMF LIFELINE, and I'm a support group leader in Oregon and Southwest Washington. We have a lot of people on the webinar. We have 657 people from 26 countries registered for the webinar. I'm very excited about our program today. It's my pleasure to introduce Dr. Guy Sherwood, who will offer his unique perspective on the patient experience of living with peripheral neuropathy, a retired family and hospice palliative care physician, and a 20-plus year survivor of WM. Guy is the former IWMF Vice President of Research. Dr. Sherwood currently teaches medical students at the University of Manitoba Medical School in Canada. Dr. Sherwood will then turn the webinar over to Dr. Todd Levine, who is the Medical Director of Neurology for Honor Health in Phoenix, Arizona, and will give us a more in-depth presentation on peripheral neuropathy. At the conclusion of Dr. Levine's lecture, we'll have a live question and answer session with questions previously submitted from the registrants. And now over to you, Dr. Sherwood.
Well, thank you very much, Joel, for that introduction. Hello to all my friends in the world of Waldenstrom's, my colleagues from the IWMF. Special thanks, Dr. Levine, for doing this. I'm going to give you a bit of a perspective on my experiences with peripheral neuropathy. At first, there's a few definitions that we have to go through, however, and the one I'd like to talk about is peripheral neuropathy, of course. And as you know, peripheral neuropathy really refers to damage to the nerves that are outside the brain and spinal column. And there are a number of categorizations of the peripheral nervous system. There is sensory, there is motor, and there's, of course, autonomic. I'm going to talk a bit about my signs and symptoms. I don't want to talk too much in medicalese, as Dr. Levine will be doing this, but my signs and symptoms, as you can tell on the slide, I had a number of them. I'll just point these out to you. These are not all representatives of my signs or symptoms, but I did have a few of them. I certainly had some sensory problems. I certainly had some numbness to touch. And I had also reduced sensitivity to temperature. I had to be very careful when I would jump into the bathtub or the jacuzzi because I could not tell how hot the water is. I could not do the old dip the toe into the tub trick because I could not feel how warm it was. I had to be extremely careful not to burn myself. I certainly had a lot of these positive symptoms, which were tingling and pain, in fact, tingling, itching or pain, pins and needles. I would notice these a lot more in the evening when I was lying down, of course, because I was not distracted by being up and walking around. I also had some motor symptoms, as Joel alluded to, mostly weakness and tiredness, but I'm not sure if that was because of the Waldenstrom's, the neuropathy, or just simply getting older. You know, I did have a fair amount of cramps, edge, muscle twitches, and tremors. I still do, but once again, this may have been likely to other factors besides Waldenstrom's peripheral neuropathy. We have to be careful as patients not to ascribe everything to Waldenstrom's. I suffer from very bad back pain, and that may have something to do with that. Autonomic nerve dysfunction, not something that we hear a lot about, and I hope Dr. Levine will talk about this, but at the heyday of my neuropathy, I made a few visits to the emergency room for irregular heart rate, an arrhythmia, if you will, and I had to be put on some medications for this. Fortunately, I was able to go off that medication sometime later. But most embarrassingly, I would be having a simple conversation with someone, and I would break out into torrential sweats. Torrential sweating for no apparent reason. I sympathize a bit with our female audience members who have hot flashes, but this was something quite extraordinary, I assure you. The other one I have is issues with pain, but I'll get to that a bit later. This is my medical history. As Joel has said, I've been around for a little bit of time in this Waldenstrom club. I was diagnosed in 2001. Like many of us, I had symptoms prior to this, but I had no idea what it was. In any event, 20 years ago, I received the diagnosis. I went about it in a pretty aggressive fashion. I had read this paper from this young researcher, you may know his name, Stephen Treon, and he, at the time, he had written a paper about treating Waldenstrom's with fludarabine and rituximab, and I thought this was very interesting, and I embarked upon that course of action, which worked quite well to arrest my aggressive Waldenstrom. I did not have neuropathy at that time, but I ended up going through a succession of treatments, as you can tell. Most recently, last year, when I had to do rituximab and bendamustine with dexamethasone, this is the continued saga, it seems, of Waldenstrom patients. The cure is elusive, but we have good treatments nowadays. If you look halfway down the slide, you can see that I went on a clinical trial for this one medication we call Velcade or bortezomib. Some of you may be aware of this. Some of you may have experienced this particular treatment. I did a clinical trial, and that was the source of my neuropathy. I was quite stubborn back in those days, still am, according to my wife, and I wished to finish the clinical trial, which was 8 cycles or 8 months, if you will. After 6 months, I was feeling a fair amount of discomfort, but I wished to continue to finish this trial. Sadly, after the 7th treatment or 7th month, I threw in the towel. I could no longer bear to receive any more Velcade as I was suffering from intense discomfort. Pain is what it was, really, from the Velcade. Despite stopping this treatment, I suffered greatly from symptoms of neuropathy, peripheral neuropathy, for the next few years. The neuropathy got worse and worse despite stopping the Velcade. It gradually tapered off, thank goodness. This is about the picture about the time that I started the Velcade trial, and you'll see my granddaughter, Nora, is in my daughter's belly there. Okay, so mechanism of neuropathy. How does neuropathy work? Well, I'm going to leave that to Dr. Levine, as he is the expert. In my case, as you can tell, I had chemo or drug toxicity. Joel talked about his neuropathy, and his was, of course, related to his IgM. Carrying on, treatment of neuropathy. Joel talked about this somewhat. There are, I think, in my perspective as a patient who suffered from neuropathy, the treatment really depends on your symptoms. If they're not too bothersome, much like Waldenstrom, if your Waldenstrom is not really causing you many problems, we don't do a lot. However, as your symptoms progress and as this impacts on your life, then symptoms are, of course, treatment is, of course, warranted, if nothing, for quality of life. I relied mostly on my mommy to help me with this. Of course, I was having a lot of trouble with Waldenstrom, as you can tell by my medical history, and I ended up getting a bone marrow transplant to stop things. And this slide is actually my transplant. This is a bone marrow transplant, ladies and gentlemen. They just simply hang a bag of your stem cells and give it to you. This is the bone marrow transplant calendar right here, and this is what it feels like to undergo a bone marrow transplant. In any event, as I carry on with my experiences in Waldenstrom's, I'm reminded that the most important thing really is quality of life for us all. As a hospice and palliative care physician, I, of course, focus mostly on quality of life. Pain was certainly my issue with neuropathy. I can handle a bit of numbness, but I can't handle a whole lot of pain. And I had horrific pain. I had acute pain from the Velcade, as opposed to, I suspect, chronic pain from what a lot of Waldenstrom's patients have from neuropathy as it comes on very slowly. This is a easy slide. not so easy, very busy, but that's why they pay Dr. Levine the big bucks, as he's very smart and understands these sort of things. And I will leave it up to him. Treatment strategy, of course, relies on stopping the underlying cause of pain. In my case, I had to stop the Velcade trial. Sadly, the pain continued for quite some time, but that was certainly the most important thing for me, to try to end this. I also believe that as patients, irrespective of whether you have neuropathy or not, one of the most important things you do is tailor the therapy to you as an individual. Not all of us do well on all the regimens. I have many friends who have done extremely well with Velcade without any problems, or the second generation of these medications. I relied mostly on quality of life things, such as sailing. That helped me a lot. The point is, I tried to live my life despite having a horrible amount of pain. There's a list here of all the pharmacological therapeutic options you have. There are many more. Dr. Levine will go through these, I'm quite sure. I went through all of them. I tried all of them. Some of them did not work. Some of them just made me goofy. And finally, I had to settle on one that is not so popular amongst the medical profession these days, and that is opioid therapy. Yes, I had to take a considerable amount of morphine simply because of pain. It worked well for me. However, as we all know, that can be quite dangerous for some people. But that's what seemed to work for me. What also worked for me was the help of my colleagues. Here there's a slide of the nurses that were part of my transplant team, and you'll notice the goofy hat, thanks to our past president, Judith May, and her husband, Michael. They gave me that to ward off the chills as I lost most of my hair during the transplant. New therapies. What can we do for neuropathy nowadays? Dr. Levine, I'm sure, will touch on that. I'm very anxious to hear what he has to say. But there's been a little bit of talk about cannabis and opioids and that sort of thing. I'm interested, but yet I understand that not everything works for everybody. And that brings me back to my main point, is to try to live your life as best you can while having these symptoms. Get educated. Ask for help from your physician, your nurses, your family, your treatment team, whoever they may be. And of course, understand full well that you're not alone in this battle with neuropathy. I don't think I was the nicest person around when I was in the throes of despair at the peak of my painful neuropathy. But thank God, this lovely young lady took a good care of me. That would be my wife, Faith. And I owe most everything to her and my family for survival through this difficult period of neuropathy. So once again, my message to all of you is to try to seek out all information possible and try not to let neuropathy get the better of you. Easy to say, difficult to do. All right. So that has been a very brief talk about my experiences with neuropathy, which, by the way, are much improved. Neuropathy comes on very quick. In my case, goes away very slow. So please beware. All right. I'm going to pass it on to Dr. Levine, whom I've known from the sidelines for quite some time. Very grateful that we have these specialist physicians who are actually interested in Waldenstrom's. They are few and far between. But thank you, Dr. Levine, for all you've done for us. And having said that, I'm going to pass it on to Dr. Levine.
Great. Well, thank you, and thank everybody for joining us today. I think that was like a really beautiful sort of personal view at how neuropathy can affect someone and all the different issues that can go into peripheral neuropathy. What I thought I would try to do is to give a little bit of kind of a broader understanding about what the role peripheral nerves have in our body. And it's important to sort of understand, kind of to start with, what we as neurologists do. So after we finish medical school, we spend 4 years learning neurology. And if you could sort of summarize all of what we learned into a single word, the word that most neurologists would use is the word localization. And that's a very, very important concept to understand. And you're going to sort of hear me talk about this a bit, but that concept basically goes sort of like this. Someone could come into my office and they could say, my foot hurts. And in the nervous system, that could be because the nerves in the foot are damaged. And we would think about that as a neuropathy. Or it could be the nerve in the leg is damaged from something else. It could be the nerves in the back. It could be the nerves in your neck. It could be the nerves in your brain. And each of those spots, each of those areas that can produce foot pain have a different set of causes. So we can't begin to talk about a cause until we know where the problem is coming from. And that process of understanding where in the nervous system a problem is coming from is the process of localization. So that's the first thing that we do. Then we can say, well, what's causing that problem? And then we can say, how do we treat that problem? It's a normal instinct for patients, and actually for most doctors, to jump right to how do we treat it. So somebody comes in with foot pain and we want to give them gabapentin because we assume it's neuropathy, but we haven't done the work to actually make sure that that's the case. So to get to that process, you have to understand a little bit about the role that nerves might play in the symptoms that you're seeing your doctor for. So if we start with that, that sort of gets us to this algorithm, which is, what's the localization of the problem? Or is it not coming from something in the nervous system? So foot pain could be plantar fasciitis, could be a broken foot, could be vascular insufficiency, and there's not enough blood flow. So there's lots of things that cause foot pain that aren't even neurologic. Then can we identify a cause for it? Now, here's the bad news, which is that in the world of peripheral neuropathy, which is what I do day in and day out, we only identify the cause of peripheral neuropathy 50% of the time. So that means 50% of the time, I am too stupid to know what's causing the patient's problem. I tell patients a lot, if I had tried to get into medical school with grades of 50%, I would not be a doctor. And yet that's the world in which we practice. We just don't understand it. My belief, although it's certainly not proven, is that the reason for that is that there are often multiple causes for a neuropathy, and we are not smart enough to understand that. So imagine throughout a person's lifetime, they've gotten certain viral infections, they've been exposed to certain toxins, they had periods of time where their nutrition wasn't very good, they have some little genetic risk factor. None of those things individually would have caused their neuropathy. When you sum them up over 50, 60, 70 years, now a person develops a peripheral neuropathy. Why do I believe that? Well, the incidence of peripheral neuropathy in people under age 20 is less than 1%. The incidence of peripheral neuropathy over age 75 is 25%. So 25% of people over age 75 have some degree of peripheral neuropathy. I think because there's been an accumulation of insults to their nerves over 70 years, and the nerves are starting to poop out. If you're in that 50% where we might identify the cause, then can we treat it? Is there a way to specifically treat the underlying disease? And can we treat the symptoms even if we can't treat the underlying disease? So that's the way we think about peripheral neuropathies. Sorry. So saw a similar picture to this in the previous talk. The idea is that nerves are really like telephone wires. And they're sending signals from the brain out to the different organs in the body, and then they're sending signals from the different parts of the body back to the brain. So all they're doing is sending electrical signals. And as we heard, there's sensory, which is what allows you to feel. There is motor, which is what allows you to move. And then there's this very complicated system called the autonomic nervous system. And the autonomic nervous system is what controls all of our automatic behaviors. So things you can't think about doing. So that's what controls your heart rate. That's what controls your blood pressure, your digestion, the way the food moves through your intestines, your bladder, those type of functions. I can't sit here and think I want to digest my food faster and have that happen. It's either going to happen or it doesn't. It's automatic. So we talk about that as the autonomic nervous system. And this is a very often ignored part of peripheral neuropathies, but can actually be, in some cases, the most devastating of the damage to the peripheral nervous system. When we talk about nerves, this is sort of to give you a basic idea of the structure of the nerve. So as I said, nerves are like telephone wires. So what that means is there's individual wires. Those individual wires are called axons. Those are put together into little bundles that we call fasciculus. And then those little bundles are put together in groups of bundles that form a nerve. So when we say someone has neuropathy, what we really mean is that something is damaging the axons. But over time, more and more of those axons get involved, and the whole nerve structure can be involved as well. We also know that the nerves are different sizes, and the different sizes of nerves don't relate so much to actually the wire, but it relates to what's wrapped around the wire, which is the yellow in this picture. And that's what's called the myelin. So there are two basic structures to a nerve. There's the axon. The axon is what sends the electrical signal. And then there's the myelin. And the myelin is wrapped around the axon, and it allows the nerve to conduct more quickly. The more myelin you have, the faster that nerve conducts, which also means the bigger your nerve, the faster that nerve can conduct electricity as well. So for example, our biggest nerves conduct at about 200 miles per hour, so about half the speed of an airplane. Our smallest nerves, called the C fibers, which are the ones that control sensation, actually conduct about 1 mile per hour, so about 100 to 1/200th of the speed. So if you think about putting your hand on the hot oven, like you're reaching in the oven to take something out, and you touch the hot oven, and then you pull your hand away really quickly, that's the slowest possible nerves that we have working in our peripheral nervous system. The fastest nerves actually control our balance. So if you think when we walk, we very quickly have to know where one foot is so we know where to put the next foot. If that doesn't happen as fast as it should, then your balance is off because your brain doesn't know where things are going. And then the motor nerves, the nerves that actually let you move, are kind of somewhere in the middle of that. So the different speeds relate to the amount of the myelin that's wrapped around the nerve. This is an example of, if any of you have neuropathy, you've probably had nerve conduction studies where some crazy neurologist takes a cattle prod and shocks you and you feel like you're in a torture movie. But the reason that we're doing that, so if you look at this here, this would be where the electrical impulse was applied. That electrical impulse will then be carried down the nerve and then make the muscle contract, and we can see that. Here, you would have the same nerve, but it's being stimulated somewhere further away from the muscle, so it takes longer to travel down here and make the nerve contract. That would be a normal nerve. If you have a demyelinated nerve, so the same nerve, now when you stimulate at that place, which should take, let's say, 4.9 milliseconds, now that whole signal takes 12.9 milliseconds before it triggers the muscle response. So it's working at about the third of the speed that it should. And that is the best test that we have to determine, is the disease process affecting the axon itself, or is it affecting the myelin? And that's very, very important to us as we think about peripheral neuropathies, because there are very different diseases that affect the axon than that affect the myelin. So that is one of our first branch points that we say, oh, this person has a neuropathy. We then say, is it an axonal neuropathy, meaning it's affecting the wire itself, or is it a demyelinating neuropathy, which means it's affecting the myelin wrapped around the nerve? Here's just a really pretty picture of an actual nerve showing what that looks like. So this would be a normal nerve. You see the axon, this darker structure in the middle, and then you see this faint light stain around it, which is the myelin. If you sort of hallucinate with me a little bit, what you can imagine is that the nerve is sort of traveling along, and then it kind of gets pinched down, and then it travels along. So here it might be pinched, here it might be pinched, here it's pinched, here it's definitely pinched. The reason that's important, and the reason that myelin allows our nerves to conduct more quickly, is that with the myelin here, the signal would come right to here, to this branch point, and then it would actually jump and go to here. If there were no myelin, it would actually have to travel all the way down the axon itself. So you actually, with myelin, you actually get the chance to kind of jump down the nerve as opposed to traveling down the nerve. And here's an example of a disease in which the myelin has been stripped off of the axon. So you can imagine how that signal might be coming down this way, and then as it hits here, it just stops because it has to take a lot longer to kind of travel through this kind of stripped off myelin point. So this is a very pretty example pathologically of when we say someone has a demyelinating neuropathy, what we're talking about. We're actually talking about stripping that myelin off of the patient's nerve. Okay, so let's talk from sort of as a neurologist, kind of what we think about when we think of what are a patient's symptoms that might have neuropathy. So I think Guy did a great job of talking about two types of symptoms, of what we call positive symptoms and negative symptoms. So when it comes to sensory fibers, a negative symptom is a loss of a signal. So think about, again, the nerves are always trying to send signals. If that nerve is damaged or that nerve is dead, it doesn't send a signal. When it doesn't send a signal, the brain is going to perceive a loss of signal. And what the brain puts in place of that loss of signal is numbness. So when you say, I have numbness, it means there's no signals coming in, which usually means that the nerves are very damaged or dead in some way. Then there are positive symptoms, burning, stabbing, tingling, electrical shocks, on and on. There's a ton. And that's where that nerve gives off the wrong kind of signal, right? So there's nothing causing a pin and needle feeling in your foot at the time. There's nothing stuck into your foot. But that nerve is sending off a signal that says there's a pin in my foot. And that is a mistake. And that's because the nerve is sick. So many patients, when they come in with neuropathy, they say, I know this sounds crazy, but my feet are numb and they hurt. And the patient can't really understand. Like if they're numb, they should be numb. If they hurt, they should hurt. Two types of nerves. You have dead nerves, that produces numbness, a loss of a signal. And you have sick nerves. The sick nerves are giving off the wrong kind of signal. That gives you, again, whatever it is, burning, stabbing, tingling, pain. Weakness is a negative symptom, meaning that you're not sending the signals down the motor nerves. And then balance difficulties is also a negative symptom. When it comes to neuropathic symptoms, we have a lot of different types of treatments. The biggest problem here, and again, I tell my patients, it's sort of like pin the tail on the donkey and I'm the blindfolded one, okay? I don't know what your nervous system needs to quiet that nerve down. And so it really is trial and error. And it really is trying to balance the side effects of the medications with the positive effects of the medications. And so you have to work with your physician very closely and find a physician who's happy to kind of do that, not just be, oh, take this. If it doesn't work, I give up. I have 50 different medications that I can use. They basically fall into three groups when it comes to the prescription medications. One are the seizure drugs, or anticonvulsants. A seizure occurs when a person has too much electrical activity in their brain. So if we want to stop seizures, we want to stop the electrical activity. The pain that you get from peripheral neuropathy is because those nerves are firing incorrectly. So if we can lessen the times that they fire incorrectly, you will have less pain. So gabapentin and Lyrica are the most commonly used, but you could pretty much use any anticonvulsant going back to the 1930s. People have tried to use these for people. They work well. The best anticonvulsants will decrease pain by 50%. So if your pain score is an 8 out of a 10, a true success is getting that pain to a 4 out of a 10. I also tell my patients, I can make your pain a 0 out of a 10, but I'll be putting you in a coma and you'll be non-functional. That's not the goal either. We need to have a balance between improving your quality of life, improving your function, and lessening your pain. But the target is not really a 0 when it comes to peripheral neuropathy because we just don't have medicines that are good enough to do that. The second category of medications are the antidepressants. So Cymbalta is approved. Cymbalta is a medication that increases the amount of serotonin and norepinephrine in the brain, and that seems to reduce our response to pain. So I think about the antidepressants as working at the level of the brain. The anticonvulsants is working at the level of the peripheral nerves. They do work well together. Other antidepressants that are common are called the tricyclics, like amitriptyline, nortriptyline. Those are often used. But again, you can choose any of them as long as they affect both serotonin and norepinephrine. The pure serotonin drugs are very good for antidepressant effects, but they don't work for pain. And then the third prescription medication, again, as he talked about, are the narcotics. It is true, doctors, particularly these days, don't like to prescribe narcotics. In the U.S., this has gotten very difficult. We are under ever-increasing amounts of scrutiny almost every year. There are new restrictions placed on us to be sure that we're prescribing these correctly. Having said that, there is a tremendous role for narcotics in treating peripheral neuropathy. I'm a big advocate of using them as long as we use them safely. And again, you can use all three of these together if the neuropathy is bad enough. Those are mainly the prescription medication groups that we talk about. There's a lot of discussion about nutritional supplements. I've taught a course at the American Academy of Neurology for a few years about non-pharmacologic treatments of peripheral neuropathy. There isn't a tremendous amount of data, truthfully. Certainly in Waldenstrom's and chemotherapeutic neuropathies, there's very little data. But in diabetic neuropathy, which is often sort of what these things get studied in, there has been some data looking at vitamin B supplements and alpha-lipoic acid. Those probably have the best data if people like the nutritional supplements. The good news is that other than B6, which actually can cause a neuropathy, there's really no toxic effect. And so trying them, I'm always for finding something that's not a prescription medication. Electrical stimulation, which is often called a TENS unit, actually was reviewed, and there is some good data on that as well. Mechanism there, we're not too sure of. People have also looked at infrared light therapy, magnetic stimulation, and actually just this week, there was a new paper looking at something called spinal cord stimulation, which is something I've begun to explore a little bit more. This is a procedure which is an implanted device into a patient's back. The electrodes are placed around the spinal cord. And so if you think that there's a pain signal coming from your foot, traveling up to your brain, we put that electrode in between that, and we try to block the signals from going up. It's used definitely in the more severe cases. It is a surgical procedure, but very little in the way of side effects other than the infection rate from the surgery. So we do have a number of different treatment options that we have for people. And as I said, it's just finding the physician who's willing to kind of work through them with you. Another important point when it comes to neuropathic symptoms is really to be careful of the feet. This, again, is true whenever anyone has what's called an anesthetic neuropathy. So again, if you have a lot of numbness in your feet, this is clearly true in people with diabetes, but could be true in any peripheral neuropathy, you don't protect your feet anymore. So you step on a little rock, you don't know that it's stuck in your foot for a couple of days until it presents with a huge ulcer like this. In the US alone, there are 40,000 amputations per year that are directly related to peripheral neuropathy. So anyone with a neuropathy needs to clean their feet every day, needs to take very good care of their toenails. As people are older, if you have a spouse or a caregiver, having them really look at your bottom of your feet, because it's hard enough for me to look at the bottom of my foot. I can't bend like that anymore. It's not going to get any easier for me. And then working with a podiatrist, where once a year you go in and really have them work with your nails, work with your skin. But this is a very serious condition, and most of these are avoidable if you take an active role in taking care of your feet. There also are a number of symptoms in the leg, so not just the foot. And so this is very important again. So people will say, I have pain in my legs when I walk. I think that's peripheral neuropathy. So one of the first questions that I ask people when they present this way is to ask them when their symptoms are worse. So if we polled the 600 people in the audience right now, I would imagine 90+% would tell me that their peripheral neuropathy symptoms are worse at night and at rest. And the reason for this is that when you have a painful peripheral neuropathy and you're up and moving around, your brain is distracted. And so your brain's not paying as much attention to the pain that's coming from your lower extremities. So that's worse at rest. If your symptoms are worse when you're walking, then there may be another cause for that. So number one, again, as Guy mentioned for himself, back pain. So radiculopathy, spinal stenosis, those symptoms are almost always worse when you walk, and they're better when you lay down. Likewise, not enough blood flow to your legs. If you have vascular claudication, that's worse when you exercise or when you walk, whereas peripheral neuropathy tends to be better when you exercise or walk. So important things, because those are very treatable causes of leg pain. And in the case of vascular insufficiency, would need to be treated. People can have other symptoms in their legs associated with peripheral neuropathy that occur at night. So this is restless leg syndrome or periodic limb movements of sleep, where restless leg means they go to bed and it's not just that they have their neuropathy pain, they get a sort of inner anxiety kind of feeling where they need to get up, move around, walk around, and it actually makes them feel better. So that movement makes them feel better. That tells you that it's more likely to be restless legs. And then periodic limb movements of sleep, often the patient doesn't even know they're doing it, but the spouse knows because they keep getting kicked in the middle of the night. And again, these are things that are very easily treatable. Interestingly, often, not that it's a cause of Parkinson's disease, but these actually respond very nicely to the Parkinson's type medications. Doctors often, unless you're a urologist or a gynecologist, don't talk much about sexual symptoms, but sexual symptoms are a big side effect of peripheral neuropathy. So particularly for men, peripheral neuropathy not only affects the sensation, which can interfere with erectile function, but can also interfere with the ability to have sexual climax. Women can have more difficulty having orgasms or can have vaginal dryness. Typically, the way to sort of distinguish this from other causes of sexual dysfunction is that with neuropathy, the libido isn't affected. It's just the ability to go through the sexual acts with people. And so this can be very nicely treated both for men and women with peripheral neuropathy. There's good data that the erectile dysfunction drugs can help with this. So basically, even if there's decreased nerve signals to the genital areas, improving the blood flow does seem to help with sexual function. So again, something that you need to talk with your doctors about. Bladder symptoms is not that common, but it can. Again, that autonomic nervous system does control our bladder function. So typically, particularly as people get older, if there are bladder symptoms, there's another cause. So it's muscle weakness, which is common for women. It's prostate issues in men. And so the first rule here is see the gynecologist or the urologist and get evaluated. There is something called urodynamic testing that allows us to see exactly what's happening with the patient's bladder. But because the nerves do talk to the bladder, and if those nerves are damaged, then there can be a loss of sensation, and the bladder just won't empty the way that it should, and then that can lead to some incontinence. So again, there are very good treatments here. Typically, medication is enough to manage these types of symptoms. GI symptoms are a big issue in people that have autonomic nervous system dysfunction. So again, the autonomic nervous system is what tells the gut to move. So if those nerves are damaged, there is a lack of motility. So you eat, and then basically the food doesn't move through the stomach very well. The typical symptoms of this can be kind of feeling very, very full or bloated early. There can also be constipation, because again, if the food is not moving through the intestines, then you're going to become constipated. This can lead to weight loss, nausea, or vomiting. Again, it's very important to see the GI doctor first, obviously. There are some good tests that can help us evaluate this, but this is a serious problem if it does occur, and typically has treatments that we can use to help with this. So the cardiac symptoms of peripheral neuropathy are also common. Again, Guy sort of mentioned this as well. So it's the nerves that tell the heart how hard to pump and how fast to pump. The nerves also tell the blood vessels how to constrict, which is what regulates the blood pressure. If those nerves are not performing correctly, then patients can have a number of symptoms. They certainly can develop lightheadedness as a result of their blood pressure being too low. If severe enough, they can have episodes of syncope or passing out. Sometimes it just causes generalized fatigue, because if your heart just isn't pumping enough blood, your body is going to be kind of chronically deprived of blood, and you just don't have the energy. And then you can have abnormal heart rhythms where it will beat too fast. So patients who have a heart rate of 60 while they're sitting will stand up and their pulse might have to get to 160. It does that to maintain the blood pressure, but that feeling of your pulse being 160 can be very uncomfortable, it can be painful, and can cause a kind of an anxiety feeling because you feel as if your heart is not behaving the way that it should. There is a type of test called autonomic testing, which can allow us to evaluate whether or not the autonomic nervous system is functioning correctly or not. As I said earlier, this is a very significant problem, because if your nervous system is not controlling your heart rate and your blood pressure the way that you should, that does lead to a higher risk of mortality. We know that this is true in diabetics. We don't know necessarily in Waldenstrom's whether that's true or not. And then we do a number of things to try to manage this. So number one, sometimes it's getting off of antihypertensives to allow the person's blood pressure to be higher. We actually want to increase the amount of salt and caffeine intake. We keep the head of the bed elevated. We use compression stockings. And then there are actually drugs that we can use to help raise the person's blood pressure if need be. Dysphagia or swallowing problems, again, not as common in peripheral neuropathies, but the nerves are telling our mouth, our larynx, our pharynx how to chew and how to swallow. And so there certainly are neuropathies in which this can be affected. You can see that the more common causes would be strokes and head and neck surgeries, but neuromuscular diseases, about 6% of all the people that have some difficulty with swallowing. So again, there may be other causes for this, but it's certainly worth talking to the neurologist about. I think this one, and Guy sort of mentioned this a bit, at least in terms of his wife, but this is a big deal. Number one, what I tell people that they have to understand is that neuropathic pain is very different than other types of pain. So if I go break my arm, it hurts, it's going to throb and be sore, and it's kind of a very constant type of pain. And I think that constancy of most pains allows our brain to sort of override it a bit and say, I'm just going to start ignoring this after a couple of days, and it seems to kind of get better, or you hurt your back, that kind of thing. Nerve pain is completely random, makes no rhyme or reason. You can be perfectly fine, and then you're sitting there, all of a sudden it feels like somebody put an ice pick through your big toe, okay? That is very anxiety provoking. If you don't know when the next time your 10 out of 10 pain is going to happen, and it could happen at any given second for no fault of your own, that produces a tremendous amount of anxiety. There's an associated depression that comes just from having to deal with that pain on a day-to-day basis. The estimates are that about 30% of people with chronic neuropathy develop some type of depression. So we really, really want to treat that aggressively. And I think sometimes it's difficult to get patients to understand that if we don't treat the mind, we can't really treat the body adequately. And so this is sort of how do we start to help the mind. So the first is, if there is a lot of depression or anxiety, the antidepressants and anti-anxiety medicines are actually very helpful. As I said before, some of them may actually help with the neuropathic pain. So it's always nice if you could take one drug, treat a couple of different problems with that same medication. The second thing that I'm a very big believer in is cognitive behavioral therapy. This is sort of a combination of biofeedback, mindfulness, self-hypnotism. I try to tell my patients it's sort of like, well, if the Tibetan monks can walk 100 yards across burning coals and it doesn't hurt their feet, that's because their mind has turned off the perception of pain. It's not that their foot isn't burning. We know their foot is burning, but their mind can turn off that perception of pain. I don't know how to teach people how to do that, but therapists, psychologists who are trained in cognitive behavioral therapy can make an enormous impact in helping people deal with these kinds of chronic conditions. And then there's a lot of good data now that exercise is really important as well. Chronic or daily exercise, as little as 20 minutes a day, actually probably improves depression. We know that. There's very good data that says that. And number two, there's now very good data to say that daily exercise improves neuropathic pain of a number of different types. So we want to kind of manage these emotional side effects and not try to minimize them because they are real. Tied into that emotional type of impact is the idea of sleep dysfunction. So first of all, if I don't sleep well, I'm grouchy and cranky and depressed. So if I don't sleep well for a year or 3 years because my feet are always hurting at night because peripheral neuropathy is worse at night, then I'm not going to really be sleeping well, and I'm going to be depressed and tired and grouchy. So it's very important to try to manage the sleep of people that have peripheral neuropathy because that's when their pain is worse. So I very often will use asymmetric dosing of medications, meaning I give them a little bit of medicine in the morning that gets them through the day because their pain's not so bad during the day. But then come nighttime, I give them a bigger dose because I really want them to sleep. And then evaluating for other sleep disorders is also an important thing to do. Okay, now this is the tough part, which is all of the medicines I might give someone for peripheral neuropathy have a huge list of side effects. And the medicines tend not to be the kind of medicines where I can say, oh, don't worry about it, nobody has side effects to this stuff. Most people will have some side effects to most medications. And so that means going into this, you have to sort of be very cautious. You have to start with low doses. You have to gradually build up the doses. And as the provider, you have to be willing to listen when a person says, this isn't working for me because of side effect. So, and again, there are many more than I've listed here, but of the antidepressants, it certainly can cause mood change, can cause nausea, can cause people to think differently. Sleep and dreams can be affected as well. So those are not uncommon. I'd say about 30% of people have those. Of the anticonvulsants, sort of, I say dizzy, dopey, stupid are basically the side effects because remember, we're quieting the nerves down, and those nerves also exist in the brain. So if I quiet the nerves in your brain down, you get dizzy, dopey, stupid. They also can cause weight gain, which is real, and they can cause lower extremity swelling, which is real as well. For the opiates, obviously the biggest risk is really probably the addiction and the tolerance issues. Tolerance means if I give you 30 milligrams today, 6 months it has to be 50, and then another 70, and it just keeps going up and up. Obviously, the narcotics can affect the way that we think. Constipation can be a very severe problem, and there are some endocrine side effects, even lowering testosterone levels in people on chronic opiates. So again, they're all real. As I said, it's all trial and error. It's just a matter of trying to find someone that you can work with and also be willing to sometimes accept, well, if I have a little bit of side effect, but a great impact on my pain, maybe I just have to live with that. But if it's a lot of side effects with a little bit of impact, that's not something you should stay on. Okay, what about treating the underlying problem in Waldenstrom's? So, and again, I think Guy sort of talked about this a little bit, but there's a few ways in which Waldenstrom's can cause a neuropathy. Probably the best described is that sometimes the IgM antibodies that are made in people that have Waldenstrom's react against a protein that sits on the surface of that myelin that's wrapped around the nerve. And so we call that myelin-associated glycoprotein. That tends to cause, as you'd expect, a demyelinating neuropathy. It is very directly related to the level of these anti-MAG antibodies. You could have hugely high IgM levels as part of your Waldenstrom's. So you could have 3 grams of Waldenstrom's and have, or IgM, and have almost no or even no myelin-associated glycoprotein. Or you could have a mild elevation in your IgM, say 800, and yet you have hugely high levels of myelin-associated glycoprotein. So there doesn't have to be that correlation, but the more myelin-associated glycoprotein antibodies, the worse the neuropathy can be. That's one way. The second way is that we believe if the IgM levels, kind of non-specific IgM levels, get so high that they start to kind of deposit into the nerves or into the blood vessels and directly cause a neuropathy by kind of gumming up the works, if you will. So very high IgM can cause peripheral neuropathy, and high levels of myelin-associated glycoprotein can cause neuropathy. These generally cause a demyelinating neuropathy, and actually a fairly specific type of demyelinating neuropathy. So we will see people that don't have a diagnosis of Waldenstrom's, we do their nerve conduction studies. It has the specific findings associated with the myelin-associated glycoprotein, and then we might diagnose the Waldenström's in that way. So the nerve conduction studies here can be very helpful if they are demyelinating. If these two things are the case and the neuropathy is bad enough, then treatment of the IgM or the MAG can be very helpful. But it's really sort of a two-prong approach. So when we see these types of patients, I work very closely with the hematologist. And the first question is, from a hematology standpoint, do they need to treat the patient's Waldenström's? If the answer is yes, they need to treat the patient's Waldenström's, then obviously move forward and treat the Waldenström's. If they say no, we really would just sort of do a watch and wait approach. Then the second question is the neuropathy bad enough that you would need to treat with chemotherapy on the basis of the neuropathy and not the Waldenström's? So we sometimes have the same yes, sometimes it's yes, no, no, yes. But if in any of those cases, we certainly move forward with trying to treat the underlying problem as opposed to just trying to treat the symptoms. Now, if we see a patient that has Waldenström's who has neuropathy, right? We'll assume for the moment that the average age of a patient with Waldenström's is 65 years old. And we know that 10 or 15% of people at that age are going to have neuropathy. That means that 10 or 15% of people who have Waldenström's will have neuropathy that's unrelated to the Waldenström's. So here again, we use the nerve conduction studies. So if the damage to the nerves looks like it's the axon, an axonal neuropathy, that's going to be less likely to come from the Waldenström's. Likewise, if the problem only affects the sensory nerves, now that doesn't mean that the person's symptoms are only sensory. It means that when we do the nerve conduction studies, we see that the damage is only sensory. Or if we have another cause for the peripheral neuropathy. So let's say the person's had 20 years of diabetes, or let's say the person got Velcade, or let's say 20 members of their family have all had peripheral neuropathy. Well, all of these things are going to make it less likely that the neuropathy is coming from the Waldenström's. And therefore, we might decide not to treat with the chemotherapeutic type agents and just treat with the symptomatic agents. So last slide, and then I think we'll stop for questions. The first thing I think is really important, which is not everything that causes foot or leg pain is neuropathy. Not every person who is lightheaded has an autonomic neuropathy. Not everybody with indigestion has a gastric autonomic neuropathy. So you still have to go back to the basic principle, which is start with your symptom. Don't start with, I want to jump onto rituximab because my foot hurts. Start with, this is my symptom, talk with the neurologist or the doctor, figure out where that symptom's coming from, and then figure out what's causing that symptom. And sometimes that means looking for other causes before we kind of jump onto the bandwagon. Most of the symptoms associated with neuropathy have reasonable ways to manage them. It doesn't mean that we fix them. As I said, 50% of patients, I don't know what causes their neuropathy, and if I don't know what causes it, I can't fix it. But I can treat their symptoms, and I can improve their quality of life and improve the things that they're able to do and really try to work. The other thing to keep in mind about peripheral neuropathy, which I think sometimes patients don't fully appreciate, is that let's say I believe a person has Waldenström's, and I believe that Waldenström's is causing their neuropathy, and I'm going to treat them with rituximab to try to lower the IgM level. There is nothing in that thought process or that treatment plan that will improve the patient's neuropathy. We have no medications to make a patient's neuropathy better. What we have are ways to stop or lessen the disease. Once we do that, it is entirely up to your own body. Your body regrows peripheral nerves. Your body can't regrow central nerves in the brain or spinal cord, but your body's very, very good at regrowing the peripheral nerves. So if we stop the disease process, then we can allow your body to regrow the nerves. the nerves start regrowing from your spinal cord, and they grow out to your arms and out to your legs, and they regrow about 1 millimeter a day. So that means for me, if I had a neuropathy and I stopped what was causing the neuropathy today, and I had 100% ability to regrow nerves, it would take about 2 years to grow down to my foot. During that 2 years that I want my nerves to regrow, I have to give my body the best chance I can to regrow those nerves. So that means being healthy. It means eating well. It means sleeping well. It means exercising every day. All the things that you would do to try to stimulate those nerves to regrow. There is nothing that we can do to stimulate your nerve to regrow beyond what your body can do. So there's a lot of work that kind of relies on you. So during that time, we have to manage the symptoms. We have to work with the person for a plan to say, how are you going to exercise? If you can't do much, let's walk. If you can't do that, let's do a stationary bike. Let's figure out what we're going to do, because if we don't do that, then the nerves won't have the best chance to regrow, and they may never regrow as good as they can. And then when it comes to managing side effects, which again is a lot of what we do, just don't, my take-home message is just don't get frustrated. I will be wrong many, many times with patients, and I will just keep saying, we'll try again, we'll try again. I don't get frustrated. I wish I could be better at it, but I don't have any way to look into a person's body and to see exactly what they need, what they don't need. So what works for the first patient doesn't work for the second patient. And as long as you can get that relationship with the doctor to work through those, almost always I can find something that's going to work. I'm not saying it's necessarily as fast as I'd like it to be, but I can almost always get there. So I will stop there.
All right. Well, thank you very much, Dr. Levine, for this excellent, clear, and concise presentation on Waldenstrom's, and in particular neuropathy. We are very grateful for your continued interest and help in this domain. We're going to go now to question and answer slides. I'm going to read out these questions, and Dr. Levine will answer them. We have a certain amount of time left. Hopefully, we can get through most of these. The first question, excuse me, from Glenn, who's from Bend, Oregon. What symptoms distinguish mild neuropathy that doesn't require medical attention from more severe neuropathy that does require treatment?
Yep. So sort of two things. So I think for most of us, if a person is starting to have motor symptoms, which means weakness, so the toes are weak, the ankles are weak, they're starting to stumble when they walk, that sort of puts it into the severe category. The second would be severe balance difficulties. So even if there's not much motor weakness, sometimes the sensory loss is so severe that the person is, starting to fall, they're bouncing off walls, maybe they need a cane or a walker. That would make it severe. And then the third is sort of the progression. So kind of like hematologists who do the watch and wait for Waldenstrom's, I like to do the watch and wait for neuropathy. And so if a person is, no different in 6 months or 12 months or 24 months, the longer they go not getting worse, then the less severe that neuropathy is. But the inverse of that is true, which is if they're worse at 6 months and 12 months and 18 months, at some point we're going to have to do something. So those are the three big ones. The most difficult is pain. And so if a person has no weakness, no balance difficulties, but severe pain, then it's really just a conversation we have to have with the patient and say, we can never guarantee that treatment is going to work, meaning Rituxan or some of the other chemos, but the pain has just become so unmanageable for you that we think it's worth a risk to do that or not. Basically, that's the main idea.
Thank you very much, Dr. Levine. Excuse me, that's so common sense, patience prevails. Yes, and in terms of pain, we can never get rid of all the pain. I think people have to understand that. Another question from Karen from Lewisburg, Pennsylvania. What should be the appropriate evaluation for a new peripheral neuropathy patient, I take it?
Well, so again, I think we start by saying, are we sure that that's what the cause of the symptom is? So that could be with a primary care doctor, but it typically sort of ends up being with a neurologist at some point. That also typically involves a thorough neurologic exam, and then the EMG nerve conduction studies, which is the most direct way to see exactly what the function of the nerve is. Once we determine that there is a neuropathy, then we look for the causes. Now, if the patient had known Waldenstrom's and the nerve conduction studies looked like a Waldenstrom's neuropathy, you maybe stop there and then move on. But even if a person has, I'll flip it around, for example. If a patient comes into me and they say, I knew peripheral neuropathy symptoms, I do the nerve conduction studies, and they have peripheral neuropathy, and the patient has known diabetes, I don't do them any good by just saying it's the diabetes. I look for other causes, because there are many other causes of neuropathy. And even though they're trying to do the best they can to manage their diabetes, what if they have vitamin B12 deficiency? Or what if they have Waldenstrom's? So I even if a person has a history that explains the neuropathy, I think you still want to do a little bit of blood work to look for other causes, because those other causes are not uncommon and could make a big difference in terms of.
Okay, I think I lost you a bit there, but thank you very much. So a stepwise and thorough approach. Thank you. Next question from Anonymous. How can you tell the difference between polyneuropathy and amyloidosis on the nerves?
Well, so it depends what you mean by that. So clinically, you may not be able to tell the difference. By nerve conduction studies, you probably can't tell the difference. So it really sort of comes down to the fact that amyloid is one of the causes of neuropathy. And so we would do blood work to look for the other causes of neuropathy. And if we saw that there was something to suggest amyloid on the blood work, we might then pursue that with other biopsies. But the diagnosis typically of amyloidosis comes from actually seeing the amyloid deposits in the nerve. So that would require a nerve biopsy, which is it's not terrible, but it's not something that's much fun. So we typically don't do that unless we suspect it. So we'd want something to suggest maybe this is amyloid, so that we saw abnormal light chains on their blood work. They had a history maybe of Waldenstrom's, and then we might proceed with a nerve biopsy.
Thank you very much. Next question from Teresa from Surrey, United Kingdom. Is peripheral neuropathy always permanent, or can we do something to reverse the damage?
It's definitely not always permanent. So as I said, nerves are very good at regrowing. So we see people that have very severe nerve injury from trauma, other types of diseases, autoimmune diseases, and their body can regrow the nerves. So the body tries to regrow the nerve. The challenge is it's kind of a struggle between whatever is causing that neuropathy and then your body's attempt to regrow the nerves. So when we treat, say, with Rituxan or other chemotherapy drugs, what we're trying to do is to give your body a little bit of an edge to see if it can regrow the nerves. So that's kind of what we're doing. So it again comes down to the question of, well, what was the cause of the neuropathy? If there's a treatment for that cause, then treating it hopefully gives the body a better chance. Shy of that comes, it sounds trite, and I say this every day, but it really comes down to being healthy, because you want to give your body the best possible chance to regrow those nerves. So you eat well, you do some exercise, you sleep, you do all of the things that you might do just to be healthy. And I've seen many people that have these idiopathic neuropathies that do that, and 2, 3, 4, 5 years later, the neuropathy is better, and we don't even really know what we treated. So it is not always permanent. Yeah.
Thank you very much. I can tell you from personal experience that my neuropathy got better over time. So it's a bit of an optimistic comment. The next question is from Ted, who hails from Nova Scotia in Canada, my neck of the woods. Is there a cure?
Again, the same answer, which is if we can know what's causing it and we have a treatment, people get better. I usually tell people, and just sort of globally, that probably our best blush at this is to stop the progression. So if someone said to me, am I going to get to be 100% better by treating my IgM levels and Waldenstrom's? I would say that's a high bar, and I'm not sure I'm going to put myself there. But I would say there's a really, really good chance that we're going to stop you from getting worse. And then over time, as your body repairs those nerves, we're going to see how much better you get. That might be 20%, 50%, 70%. We don't know that because, again, it's up to each individual person's body.
Thank you. And a bit of a related question, if you will, with respect to individualized therapy, and a question from John from Wilmette, Illinois. Does pregabalin, Lyrica, as some of us know it, help bortezomib-induced neuropathy? If so, how much pregabalin per day? Does the body get used to it such that the dose should periodically be increased? If so, how often? A lot of detailed questions, but do your best, Dr. Levine.
Sure. So Lyrica is a very effective drug for peripheral neuropathy. So I would say there's probably a 70% chance that for anyone with a painful neuropathy provides some benefit. So it's about 70% probably that improve. As I said before, I think the best that we do is about a 50% reduction in pain. So I think managing expectations with this stuff is very important. So if you go into it and you say, I'd love for my pain to be 50% less, this is a reasonable thing to try, but there's no guarantee. How much is very independent. It's different for each person. I have people that take 25 milligrams at night and are perfect, and I have people that take 600 milligrams a day. I don't think there's a tolerance effect to Lyrica the same way that there is to the narcotics. So typically, once you find a dose that works, that you can tolerate, that dose seems to work for a really long time. Now, that's always difficult because if the neuropathy gets a little worse, then maybe you need a little more. And I don't know if that was the neuropathy getting worse or a little bit of tolerance to the medication, but it's not a medicine that we see a lot of that kind of dose escalation with. So, we like it a lot as long as people can manage the side effects.
Thank you. Next question is from Deborah from London, United Kingdom. And this one is a bit in my wheelhouse as I dealt with a lot of pain management and palliative care during my career. The United Kingdom does not use the same pain control meds. What medications are used in the United Kingdom for peripheral neuropathy? I'm not sure if you can answer that, Dr. Levine. All I can say is that as a palliative care physician, I dealt with people who had a tremendous amount of pain at the end of their life, usually. And it was a question of, as Dr. Levine mentioned, managing expectations for one thing, super important with pain control. And secondly, trying to see what works. And there's no one drug that works the best for everybody. What do you think about this, Dr. Levine?
I agree completely. I don't know exactly what. I know that obviously they have a little more limitations in their medications, but I would think the medicines that I mentioned now in the US are all generic, which means they've been out for a very long time, which usually means that the UK has them readily available. So I can't imagine that they don't have gabapentin. The tricyclic drugs like amitriptyline, nortriptyline, I would think certainly. Lyrica, I think, again, within the last couple of years, I would guess they're starting to use. And then the other SNRI drugs, even if they don't have Cymbalta, there's one, for example, called Effexor, which I like, very old, and I'm sure they have. And then for the more severe pains, I'm sure they have the same types of narcotic medication. So I would think it's pretty close to what I described in this talk. I wouldn't think if there's a big difference, but I'm not certain.
Absolutely agree. Sometimes it's just a question of the different names for the same drug that we have from different countries. Next question, Linda from Bismarck, North Dakota, just south of where I live. What non-prescription techniques can be used to help treat the pain of neuropathy?
So I'm a big fan of non-prescription techniques. The challenge, and it's been a few years, but I've reviewed this literature fairly extensively in the last few years. There isn't great data. So, I can tell you, well, 70% of the people have some response to Lyrica. The best you can do is a 50% improvement in pain, and that came from a double-blind placebo-controlled trial, and I feel very confident in that data. When we get into the non-prescription world, my confidence in the data goes down. Having said that, I have had patients get benefit from acupuncture. I've had patients get benefit from chiropractic manipulations. I've had patients get benefit from the TENS units, the electrical stimulation. You can buy those on Amazon for like $40. I've had patients get benefit from laser therapy. So I'm not at all opposed to those. Sometimes in the newspapers, you will see these neuropathy clinics, and they give you a free dinner, and then they want you to spend $3,000 and go through all their treatments. I always talk about risk versus benefit. What they're going to do doesn't have any medical risk, but there is financial risk. And if my patients are spending a lot of money on unproven techniques, it always makes me a little nervous. But again, I think that's for every patient to kind of decide. So I think all of those things make perfect sense. I just can't really tell you in a good study how likely they are to work, but they also don't hurt. The same, it can kind of be said for the supplements. Again, I think the one exception, and when patients ask me, I do recommend, at least a B complex and then alpha lipoic acid, because there have been some pretty good studies done by the Mayo Clinic in diabetic neuropathy that if you do those things over time, the nerves do a little bit better. But again, I think that's all part of the give the body the building blocks it needs to try to repair the nerves. And those types of treatments are not something you should expect that you're going to take for a month and feel better. Those types of treatments are, I'm going to take for a year or two, because that's how long it takes for my nerves to regrow, and hope that it helps.
Thank you. I think vulnerable people, vulnerable patients need to be wary of outrageous claims. Outrageous claims require outrageous evidence. So be careful when something seems too good to be true, would be my advice to people. Another question from Julie from Eugene, Oregon. Does exercising help? You talked about this earlier. Are there any specific exercises that are useful for improving neuropathy?
So there hasn't been as much research into specific exercises as I wish there would. But on the other hand, that makes the answer to this really pretty simple, which is 20 minutes a day of anything is actually what's important. And the key is that very often, and I stopped doing this, 10 years ago because I got frustrated. I would send patients to physical therapy to help with their neuropathy, and they would go spend an hour with the physical therapist, and then they'd be in so much pain they did nothing for a week. And that completely defeats the purpose. So the goal is simply daily, literally 7 days a week. So if you can get into a religious habit of just walk out your door for 10 minutes and walk back, or get on a stationary bike, or now that it's the summer, get in the pool. Aquatic therapy is always great. But we don't know exactly which ones are which. At my institute, we now have put in a large exercise physiology department, and I'm trying to study that, but we're probably years from knowing that answer. So really, I just tell people, whatever you want to do, 20 minutes a day. But it's daily is the key. Yeah.
Thank you. Next question from Brian from British Columbia in Canada. When I do any extensive cardio workout, my feet, I think there's a typo there, my feet always feel better for the next little while. Is that due to better blood flow to the extremities? Question mark.
Yeah, so it's I don't really know why, but it gets to what I kind of said before about how I tell the difference between peripheral neuropathy symptoms and, let's say, back symptoms was a common overlap of those two. Back symptoms usually don't get better when you're exercising. They tend to get worse the longer you exercise. Peripheral neuropathy symptoms get better when you exercise. I think blood flow is as good an explanation as I can give. It may simply be that you're stimulating the nerves and that's somehow overriding the bad signals. And then maybe, again, in my mind, maybe that stimulation, which is what's done every day as part of daily exercise, is what eventually allows those nerves to sprout and to regrow. But I can't prove any of that.
All right, fair enough. Next question from Linda. Linda has a couple of questions, actually, and we'll try to split these up. Can regular massaging of the feet impact one's neuropathy? And does dill pickle juice or Dove soap by one's feet at night have merit for neuropathy or for restless legs? Or I'm sure patients have asked you all this before.
Yeah. So massaging, again, I don't know. Certainly if it feels good, it's fine. Any great reason to believe it's changing the course of the neuropathy. It doesn't hurt you. And obviously if it feels good, it helps you sleep, then I'm all for that. The pickle juice is something that people have used, I think, for 100 years now, to help with muscle cramps. And what it does is it actually increases the amount of electrolytes in a person's blood. And so it's actually, I don't like pickle juice, but it's actually a very, very effective treatment for the cramps that come from peripheral neuropathy. And even heard presentations at our national meetings about that still, which is kind of interesting. And then I'm not sure about the Dove soap, what that would do, truthfully. I don't know. Have you heard anything about that, Guy? Or?
Well, I have to admit, I've been asked that question many times. We know patients who are oftentimes desperate for relief. I certainly was desperate for relief. I tried almost everything, but I've not tried it. I don't know if it works. Maybe it makes your feet smell better. I don't know. Okay. Joyce from Essex Junction in, this must be Vermont. Does rubbing CBD oil or tinctures into your muscles have any merit? And this relates to the use of cannabis as opposed to treating neuropathy.
So I didn't talk about that, but I guess I'll talk about it now. So sort of two answers to that question, and this is very much my bias. So I don't have data to support this. I have lots of people who try CBD oils in one form or another. I mean, either drops of it or rubbing it on muscles. My experience, probably from hearing back from hundreds of patients, is I don't think it does very much. There's certainly no risk to it. And so if you want to try it, I'm all for it. But if patients ask me, what I typically say is I don't think CBD does very much. On the other hand, medical marijuana, which is THC with CBD, I think is highly effective. I think it improves sleep, which again can be a major issue in patients with painful peripheral neuropathies. I've had many patients that were on high doses of narcotics who were able to get off by transitioning over to medical marijuana. I actually think that's probably safer in the long run for them to be on that. So I am sort of a fan of medical marijuana, and I mean, in my state now it's legal anyway, but not so much a fan of CBD, and that's just my personal anecdote. But I think the combination, I think the THC in medical marijuana is helpful. I think, as I said earlier, the pain that comes from peripheral neuropathy has an anxiety component. It gets into people, their skin. It's just. And I think that the marijuana helps with that, helps with the sleep, and helps with the pain. The American Academy of Neurology did a large review on medical marijuana. It's been several years now. But one of the things that they found the best data for was to help with muscle cramps and muscle spasticity. So it's very effective for that. We use it in people with multiple sclerosis and strokes and all that. So I do like that if where you are located allows you to do that. I think that's definitely something worth doing.
Yes, and as a former palliative care and hospice physician, I would totally agree with you. I think there has been quite a lot of benefit with the use of medical cannabis for a number of conditions, but certainly for pain and spasticity, I've used it a lot in my patients with very good results. And it's legal in Canada. Next patient, James from Lemon Grove, California. How common is it to develop restless leg syndrome as a result of peripheral neuropathy?
It's very common. It's probably about 50% of people with peripheral neuropathy who have some degree of restless leg syndrome. And the challenge is that while some medications like gabapentin is approved for both peripheral neuropathy and for restless leg. And that can be very convenient because you give someone a big dose of that at night, it helps with both. But in some cases, it's not enough. And then you have to go to some medication to help with the peripheral neuropathy pain. and then the separate specific restless leg syndrome type medications, which really are more like the Parkinson's medications. And it can also be very difficult, I find when I talk to people, for them to really sometimes separate it out. So, what's keeping you up at night? Is it the fact that you have to get up and walk around because the leg is giving you this achy, uncomfortable feeling, which is the restless legs? Or is it this sharp stabbing pain, which is keeping you up, which is the peripheral neuropathy? So you have to kind of figure out which of those two things do I need to give a little more medicine with in order to improve their symptoms. And then the other misconception is that restless leg syndrome does occur during the day. So most people have it only at night, but it can occur during the day as well, which can then also be confused even more with the neuropathy. So, but it's patients generally have a different description. The restless leg is this inner anxiety, uncomfortable, achy feeling where they have to get up and move around. Peripheral neuropathy is the typical neuropathic pain where sometimes getting up and moving around feels better, but it's not like they're driven to get up and move around.
Thank you. I think we have about time for maybe one or two questions. This one's a bit more involved. Daniel from Ontario, Canada asks, I've been diagnosed with small fiber neuropathy. Anti-MAG and other similar tests came back negative. How does small fiber neuropathy differ from the points of view of progression, impact on quality of life, and management?
Yeah, so that's a whole other lecture. I've done a lot of research, a lot of research on small fiber neuropathy. So very quickly, the idea when I showed that picture, there are some nerves that have no myelin wrapped around them, and those are the nerves that are involved in sensation. And so we call those the small fibers. In most neuropathies, diabetes, typical Waldenstrom's, B12 deficiency, all the different sizes of nerves are affected the same. In some people, only the small nerve fibers are affected. And so we call that an isolated small fiber neuropathy. That almost never, I mean, nothing's never, but that almost never evolves into a more widespread neuropathy. So that means it doesn't affect balance and it doesn't affect weakness, but it does cause a tremendous amount of pain. And so, like we've talked about before, if we could identify the cause of the small fiber neuropathy, we would treat the cause and hope to make it better. If not, then we just kind of manage the pain that comes from the small fiber neuropathy symptoms. I typically tell my people with the idiopathic small fiber neuropathies, it's not going to put you in a wheelchair, it's not going to disable you, and we'll be able to find medications that can manage the pain, but it typically is something that kind of stays there. So there's going to always be some of that pain, some of that sensory stuff.
All right. I think that's it for us in terms of questions, as we have a few other things to do, but I really want to thank you, Dr. Levine, for just an excellent talk, a very common sense approach. And I hope that many of the participants in this webinar have learned a lot from your talk and your answers. Thank you so much. I want to take time to say hello to all my friends and to say how grateful I am to all the volunteers in the IWMF and the staff as well for all the hard work they do. Thank you very much. Over to you, Joel.
And I would like to thank you both for participating, and thank Dr. Levine for speaking to Waldenstrom's patients. I know you've done this before. And thank Dr. Sherwood for all that you do for the IWMF. And I must say, since I developed my motor neuropathy in 2014, I've looked at neuropathy information, but I gained some new information in this seminar. You can always learn more. And thank you for answering all those questions. Now, we want to develop peripheral neuropathy support groups in the IWMF. There was a question in your registration about it, and you could indicate interest, and we did have quite a bit of interest. I think about a fourth of the people who registered were interested in a support group. If you did not check that on your registration, you can contact the IWMF at office at IWMF.com and indicate that you would like to be considered for the support groups, which will be starting in a while. We would like to thank the sponsors for today's program: Bigene, Janssen Pharmacyclics, Treadway Foundation, X4 Pharmaceuticals, and the Leukemia and Lymphoma Society. The IWMF is extremely grateful to all of you in the audience for being with us. We hope you enjoyed today's educational seminar and that you learned a lot. And remember to check the IWMF events website calendar and watch for emails announcing the next 2021 Global Patient Education webinar, which is being planned for October. Thank you very much. And that's great to have you all with us.